Fine.
Perfect.
You'll be sharing your own slides, Cheryl?
Yes, I will.
Okay, thank you.
Hi. Morning, everyone.
Hi, Cheryl. Okay, we are now 1:30 and we are live. Hello, everyone. We'll just start in about a minute because a lot of people are starting to join in. Thank you very much. So let's now start. And I'm Dr. Pauline Chan. I'm the Regional Advisor for HIV. Good morning and good afternoon, good day, everyone. I'm Pauline Chan. I'm the Regional Advisor for HIV, Hepatitis, STIs, and Elimination of Mother-to-Child Transmission at the WHO Southeast Asia region. Welcome to the WHO Southeast Asia Regional Office commemoration of the World AIDS Day 2025. This year has been another year of the unprecedented, when we all thought that the path was clear and the path was to continue recovering from the COVID-19 pandemic in Asia. The very substantial cuts in global health funding this year has shaken the entire world of health and development. Now let's proceed with the program. I'd like to call upon Dr. Suman Rijal from the WHO Southeast Asia region, the Director of Communicable Disease. Over to you, Dr. Rijal, for the welcome remarks.
Thank you very much, Dr. Pauline. Very good morning and good afternoon to you all, wherever you are. Dear colleagues, partners, friends, a warm welcome to all of you as we come together to mark World AIDS Day 2025 under the theme Overcoming Disruption, Transforming the AIDS Response. Across the WHO Southeast Asia region, the burden of HIV, viral hepatitis, and sexually transmitted infections remains significant. Last year alone, 88,000 people were newly infected with HIV, and around 50,000 people lost their lives to HIV-related causes. Today, 3.5 million people in our region are living with HIV, alongside 42 million with hepatitis B, 7 million with hepatitis C, and 60 million with STIs. We all know who is being left behind. HIV prevalence remains disproportionately high among men who have sex with men, people who inject drugs, transgender people, sex workers, and their partners. Young people account for nearly a quarter of all new infections in the wider Asia-Pacific region. Yet, we have seen important progress. Antiretroviral therapy has helped reduce AIDS-related deaths by 62% since 2015, and new infections have declined by 32%. Today, 85% people with HIV know their status, 74% of them are receiving treatment, and 72% have achieved viral suppression. And this year, Maldives became the first country in the world to be validated for triple EMTCT of HIV, syphilis, and hepatitis B, a remarkable milestone that shows what is possible. But gaps remain, and reaching the 95-95-95 targets and ending AIDS as a public health threat will require renewed commitment, innovation, and investment. Today's webinar is an opportunity for us to reflect on the 6 strategic actions the region must prioritize: accelerating the testing to treatment cascade, integrating EMTCT and reproductive health services, expanding equitable access to new prevention tools, strengthening data systems, including responsible use of AI, safeguarding financing and system resilience, and empowering communities while upholding rights and eliminating stigma and discrimination. WHO remains committed to supporting countries to drive these priorities forward, strengthen health systems, and to ensure that no one, especially the most vulnerable, is left behind. Thank you for joining us today, and I look forward to our discussions on how together we can transform the AIDS response for the future. Thank you very much. Over from my side.
Thank you very much, Dr. Rijal. And before we start with the program and the presentations and panel discussions with implementers, communities, and healthcare providers, let's start with the housekeeping so that the participants will can understand where to resource the Zoom link. So for questions and chat, please use the Q&A feature for questions regarding the topic and presentations. You can use the chat feature for questions or for IT or logistics or to introduce yourself. So please introduce yourself on the chat. It is an open chat. For live transcription, click on live and transcript and choose show title, subtitle, and the caption will appear on the screen. To close the caption, click hide subtitle. This live caption basically. The session is being recorded and your attendance is consent to be recorded. Session materials, including session recordings, will be uploaded on the ECHO platform in the days following the webinar, and your feedback is important to us. A survey will be shared at the end of the session. In data use, Project ECHO collects registration, participation, questions and answers, chats, comments, and poll responses for this program and shares this with WHO. Your individual data will be kept confidential. The data may be used just for reporting on maps and communication surveys, and it's really to help us to improve our reach out and the webinars better. So for this World AIDS Day, we are going to have setting the context by UNAIDS, panel discussion and Q&A, and some summary and closing remarks. And with this, let's start. So without further ado, I would like to invite Kincho Wintin from UNAIDS Asia Pacific Regional Support Team, who will speak on the Global AIDS Strategy 2026 to 2031 regional directions. Over to you, Kincho.
Thank you very much, Pauline, and good afternoon, good evening, good day, distinguished guests, colleagues, and friends. And we would like to thank WHO SEARO for inviting the UNAIDS regional team to this important World AIDS Day event. I'm Dr. Kincho Wintin, HIV Prevention and Treatment Advisor from UNAIDS regional team, and it is such a privilege to represent UNAIDS and share insights on the Global AIDS Strategy 2026-2031. So over the next few minutes, I'm going to walk you through the key elements of the Global AIDS Strategy and the regional directions for Asia and the Pacific. So let me start with the Global Accountability Framework for HIV. The Global AIDS Strategy is a key component of the Global Accountability Framework for HIV, and the joint program supports this accountability for the HIV response to ensure that everyone is served. And as you can see in the slide, it is done through four-pronged approach, beginning with the Global AIDS target setting process, which is then translated into the Global AIDS Strategy. The strategy then leads to the high-level meetings and political declaration, which then feeds into the development of the national strategic plan at the country level. And once the NSPs are developed, the joint team then works together with the countries and community on routine basis to monitor the targets. And also, I would like to touch a little bit on the visions of the Global AIDS strategy. The next Global AIDS strategy is about action and alignment, and it calls on us to focus on impact and feasibility, tackle stigma and discrimination, and address inequalities that drive the epidemic. As briefly mentioned by Pauline, that we've been struck by the unprecedented crisis. So this vision is rooted in today's realities and shaped by the urgency of now, and defining what is needed to sustain the HIV response and deliver the results. So this is just to quickly show you the timeline of the Global AIDS strategy processes. And as you can see, the process has been highly consultative, involving multiple phases, from the scoping, defining problems, to prioritization and the adoption as the last phase, the phase 6. The regional and global consultations, including those with communities and experts, have shaped the strategy to reflect diverse perspective. The next phase, the phase 6, will be started with its adoption at the upcoming UNAIDS Program Coordinating Board that will be in next week, and after that, it will be adopted at the high-level meeting in June next year. And let me focus on the key shifts between the previous strategy and the new strategy. Basically, we move from a scale-up HIV response towards ending AIDS and building sustainability. And the focus changes from the intervention-centered to people-centered. And instead of having numerous broad targets, the new strategy promotes fewer but actionable targets that country can adopt. The strategy also advocates for integration of vertical HIV programs into broader national health programs. And the service delivery will diversify through self-care models, differentiated services, and community-led approaches. And importantly, the strategy advocates for community-owned and led responses with shared responsibility, differentiated by income, reducing reliance on donor-driven models. And finally, it promotes both global and regional strategies for better alignment and impact. And the foundation of the new strategy are rooted in equity, dignity, access, stigma and discrimination-free care for all. And as you can see from the slide, by 2030, the vision is clear. 40 million people on HIV treatment and virally suppressed. 20 million people will be using ARV-based HIV prevention options. And these goals reflects a rights-based, gender transformative approach and prioritize integration of HIV services with broader health system. The strategy emphasizes sustainability and resilience, calling for strong community engagement and investment in essential data system. Ultimately, the foundation is about creating a people-centered response that accelerates progress towards ending AIDS as a public health threat by 2030. So we touch upon the vision and foundation of the strategy, and now let me move on to the 3 priority areas. The strategy sets out 3 priorities that are essential to achieving the goals as mentioned in the previous slide. So the first priority is around sustaining the response, that is to build country-led resilient systems ready for the future. The second priority is around the people-focused services that guarantee equity, dignity, and access to HIV testing, treatment, and prevention free from societal barriers. The third priority is around powering communities to lead, that is to strengthen leadership, service delivery, and accountability by institutionalization of community roles and ensuring that community have resources and capacities to lead. So In a way, these priorities will work together to ensure that the response is sustainable, right-based, and adaptable to future challenges. So this is to unpack 3 priority areas that I mentioned in the previous slide. In the current Global AIDS strategy, we have 17 result areas for action, but new strategy propose 8 priority areas here to build programmatic, political, and financial sustainability. So basically under priority 1, sustaining the response, the emphasis is on financing, integration into broader health system, and investment in data systems. Under priority 2, it is about the people-focused services, and the recommendation focuses on scaling up innovation prevention options, promote equitable access for HIV services while addressing societal barriers. And for the priority 3, the recommendations from the community consultations are very clear, and they propose how to better integrate community-led systems into the national response while promoting the key role of communities for the leadership, service delivery, and accountability. And all these requires local, regional, and multilateral actions to end AIDS. So this is just to quickly show you on the targets. So it is clear that more than ever, we need an ambitious, focused, and targeted strategy. So the Global Task Team on Targets for 2030 recommended 16 top-line global targets and 50 second-tier targets. Top-line targets, as you can see from the slide, are grouped under 6 areas of treatment, prevention, stigma and discrimination, community, integration, and sustainability. While the strategy will determine the strategic actions that are needed to reach the targets, or in a way, the hows, the targets will provide the direction of the travel, the what's. So the targets aim to simplify the accountability while addressing the evolving challenges that we face since the beginning of this year. And the number of the targets that were in 2021, 2026, or the current global AIDS strategies are recommended to be extended to 2030, for example, 95 targets, because they have not yet achieved by many countries, and it remains critical for ending AIDS as a public health threat by 2030. And now let me focus on zooming in on the regional chapter, Asia-Pacific regional chapter of the Global AIDS Strategy. For UNAIDS, we have the regional coverage of Asia and the Pacific that is more or less equivalent to the SEARO and WIPRO, the regional country offices. So in the slide, as you can see, the Asia and the Pacific chapter, regional chapter of the Global AIDS Strategy is informed through multiple thematic consultations that happened in April. It started with integration of services, followed by prevention, community leadership, and stigma and discrimination. And these consultations provided the basis for drafting of the regional chapter, which was then discussed with the UN Regional Interagency Team on AIDS in August to ensure alignment with the regional priorities across all the co-sponsor agencies. Again, the draft was further discussed through a community dialogue in early October to ensure that perspectives from communities were incorporated into the regional chapter. So the framework of the regional priorities follow 3 overarching priorities as set out in the global level, but we spell out in detail of what is needed in our region. So the first priority focuses on country-led HIV responses that are resilient and sustainable. So basically, it will focus on sustainability across the dimensions of programmatic, political, and financial. And domestic financing is central, and countries are encouraged to increase national investment for health and HIV. It also emphasizes on the importance of integration of HIV services within broader health systems, including primary health care, sexual and reproductive health, mental health, and harm reduction services. And we also included leveraging community systems as part of the sustainable pathways under this priority. Robust data systems and financial trackings are also essential for improving efficiency, transparency, and decision-making. So overall, this priority aims to create resilient systems that can adapt to future challenges while sustaining HIV response and ending inequalities. The second priority is about delivering people's focused services that ensure equity, dignity, and access. The focus areas are to expand prevention choices by scaling up combination prevention and harm reduction with emphasis on PrEP for key populations. And innovative service delivery will also need to be expanded through the adoption of differentiated models to improve reach and convenience. And it will also focus on strengthening HIV literacy using digital platforms and culturally tailored education. It also emphasizes on early initiation and access to optimal ARVs and to end vertical transmission through integrated services. Another important aspect is equitable prices and access for ARVs and diagnostics across countries, including innovative HIV prevention commodities. We also need to advance legal and policy reforms to tackle stigma and structural barriers. Overall, this priority aims to combine biomedical, behavioral, and structural interventions in integrated and right-based services. Priority 3 focuses on community leadership as a cornerstone of the sustainable HIV response. It includes strengthening and institutionalization of community leadership, support community-led service delivery, and strengthening community capacity and accountability. It has only 3 broad priorities, but very important and powerful. And the Global AIDS Strategy emphasizes that communities are not just implementers, but equal partners in decision-making and accountability, ensuring that services are right-paced and responsive to local realities. And actually, this is my last slide, and it is picked up from the recently published UN AIDS World AIDS Day 2025 report. The warning is very clear. If we stay at 2024 prevention and treatment levels, ending AIDS by 2030 will remain a distant dream. Without renewed commitment, new HIV infections will rise. It will undo all the decades of our efforts and progress. And disruption in prevention, treatment, and community services taught us painful lessons and demand bold action now through resilience, innovation, and political leadership. So the Global AIDS Strategy shows us the path. So the choice is in the hands of all stakeholders. We act now or we risk losing the fight. Thank you very much, Pauline. Back to you.
Thank you very much, Kin Cho. And I have to say that I am shocked by the latest data on undoing the gains that we have hard fought in the last the 4 decades, I would say, of AIDS response. But let's go back to the conversation with implementers and people at the ground level. And our next speaker, as part of the panel, is Dr. Arun Kumar Govinda Kanava from the WHO Nepal office, who will be talking on how Nepal has adapted to the recent funding disruptions and what kind of collaboration will support Nepal in maintaining, sustaining, and accelerating the AIDS response towards ending AIDS. Because the goal now is not about control, it's just trying to end AIDS by 2030. Over to you, Dr. Arun.
Thank you, Pauline. Can you hear me?
Yes, please go ahead.
Yeah. So the recent funding disruption posed a major challenge to Nepal's efforts in preventing and controlling and eliminating HIV/AIDS. However, particularly on the prevention aspects, these funding cuts had a major impact on the prevention aspects. However, Nepal has strategically protected the care part of the HIV. The HIV testing treatment programs were protected through sustained domestic financing, particularly for essential commodities like HIV tests and making ART available at hospitals and providing facilities for viral load testing. ART and viral load testing is provided free of cost to all people living with HIV across the country. And Nepal also domestically supporting the PMTCT programs, mainly focusing on prevention of mother-to-child transmission of HIV, with a commitment to expand that to elimination of mother-to-child transmission on the triple elimination targets of has been agreed upon, and currently exploring ways to integrate these triple elimination programs with TB, leprosy, and maternal, newborn, and child health programs to ensure sustainability. So in this aspect, Nepal is collaborating with the WHO and UNICEF to develop a roadmap for EMTCT and to implement in Nepal. So the major areas supported by the Global Fund are basically the prevention aspects of HIV prevention. So that is really severely affected in Nepal with this funding crunch. And if you talk about collaboration, the regional collaboration, you were also asking about the regional collaboration or also whether inside national collaboration?
Both.
Both.
It's
Okay.
collaboration
So
all around.
all around. So this is what national level collaborations with developmental agencies, etc. I have already mentioned to maintain the care pathway and also to support the prevention aspects. Coming to the regional collaboration, Nepal recognizes HIV also as a cross-border issue in Nepal because a large number of Nepali population migrates to neighboring countries. Labor migration is a major issue. So the collaboration between the neighbors is important, particularly the neighboring countries like India. So the constant collaboration, data sharing can help prevention and treatment services across the borders. The recent meeting with NACO in India, facilitated by WHO SEARO, focused on cross-border collaboration and ensuring access to HIV care and support for migrants has really helped. And we are looking forward to the actionable collaborative programs in that account. Nepal continues to work closely with the WHO, UNAIDS, UNICEF, and other UN agencies in the country and the region to support various of these efforts. And we are also looking forward to the regional procurement mechanisms and pooled funding initiatives that's particularly for medicines. Secure ART and HIV diagnostics and other essential commodities, particularly when it comes to important, hard to procure medicines. Nepal faces challenges due to limited quantities and local availability issues. So a regional procurement mechanism can be of very, very helpful to Nepal. WHO's regional and global expertise in strengthening countries' plan also will benefit Nepal for particularly HIV drug-resistant surveillance. This is another collaboration we are looking forward to, and also disease burden estimation, STI surveillance, and AMR surveillance, particularly focused on gonococcal infections. So these are some of the collaborations which we are currently doing and also looking forward to it. So on behalf of Dr. Sarbesh Sharma, Director of National Center for AIDS Control and Sexually Transmitted Infection Control, I am representing him today. because he could not be here today. Over to you, Pauline. Thank you.
Thank you very much, Dr. Arun, and please convey our kind greetings to Dr. Sharma of the National Program
Sure.
of Nepal. And so there are many points that are discussed in the points that you brought up just now, including integration,
Yeah.
and leveraging the national strategic plans and making sure that you have concrete roadmaps. And really looking into collaboration at different levels, at multiple levels, and ensuring that WHO remains key to providing technical assistance to trying to unblock some of the barriers and challenges that the country is facing. But what is coming out really clearly is that HIV prevention has been severely affected. And this is what we will hear now from our next panel, who's coming from very key organizations of communities across the region. So the first among the three panelists from communities is Mr. Midnight Punkasetwatana from APCOM. Midnight, thank you very much for being here today. And Midnight, so how have the disruptions affected the LGBTQI communities, and what needs to be done to safeguard their rights and access to services? Over to you.
Thank you so much, Pauline, and thank you everyone at WHO SEARO for this webinar, and thank you everyone for joining, and an early happy Human Rights Day for tomorrow as well. So for APCOM, which work on LGBTI issues across the Asia-Pacific region, the lives of us has always been negotiating risks. So risk of being seen, risk of being judged, risk of being punished simply for existing. So when disruptions happen, whether from public health emergencies, political tensions, or social unrest, they don't only disrupt services, they shake the very essence of safety for many of us who work so hard to build this space. And over the past years, we have seen our community pushed even deeper into vulnerability. So when clinics are reducing their hours, some people having to quietly run out of their antiretrovirals, and when travel restrictions were enforced, many trans people were not able to go across checkpoints to pick up their hormones or accessing PrEP. Some have had to hide their medication at home to avoid questions from family members. So this was during COVID-19, and now many of our communities have lost their jobs, and that loss of income also comes a loss of fear for not being to afford care going forward. In several countries, we also witness something more painful: increasing policing, raids, arrests, and public shaming. So moments where LGBTQ people are not being treated as patients or as citizens or as human beings, but as problems to be controlled. So these incidents create really deep wounds for our communities. They send a message to the wider community that we are safe nowhere, not even in the most private moments. And when people feel unsafe, they stop seeking help. They disappear from systems that were meant to protect them. So this is not just a physical world, it's digital world as well, which has become a lifeline for so many and has become more dangerous. So outreach posts were removed, helplines are targeted with harassment, and personal details of queer individuals were exposed. Even online, people hesitate before reaching out for support. But despite all of this, we witnessed remarkable strength in the community. When formal systems were overwhelmed, the community held each other up. So peers delivered antiretrovirals on motorbikes, and including for prevention as well. Volunteers turned their homes into small community clinics and safe spaces. Organizations were set up with WhatsApp line, so no one would feel alone. So in our cultures, where family and togetherness are deeply valued, LGBTQI people build their own version of the family when the world is closing its doors. And so what must be done? Of course, first, we need to acknowledge that health and human rights cannot be separated. Kinsho already mentioned the new strategy is being developed, which has a very strong component of the community and also people-centered approaches. People cannot trust the health system in the fear of being profiled or arrested on their way to the clinics. We cannot claim that no one will be left behind when the law still criminalizes the identity and who they love. Decriminalization, protection from police harassment, and the end of forced disclosures are not political positions. They are very much a basic public health requirements. And secondly, we must invest in community-led systems because they are proven and they are effective. Across the Asia-Pacific region, when everything else stopped, LGBTQI networks continue to deliver services. They know where the people are, how to reach them, and how to support them with dignity. Community-led testing, community-based PrEP, telehealth, and multi-month dispensing should no longer be exceptional measures. They should be a standard by now. And thirdly, we must protect digital spaces. For LGBTQI people, mobile phone is often the safest doorway to information, counseling, and emergency support. We need stronger privacy protections, better platform accountability, and improved digital safety so that online support becomes a reliable place of care. And lastly, we need LGBTQI people to represent in different decision-making spaces. The Asia-Pacific region is diverse, culturally, and also very complex. Policies designed without lived experiences often miss the realities on the ground, so our voices must not be treated as optional. It's really essential. So in closing, if there is one lesson learned from these disruptions, it is that the LGBTQI communities will always find ways to survive, but survival should never be the expectation. LGBTQI people deserve safety, dignity, privacy, and meaningful access to health services every day, not only during crisis. So the path forward must be grounded in compassion, in human rights, and in the understanding that the Asia-Pacific region, healing is not just about access to medicine, it's also about belonging and being seen and being treated as fully human being. Thank you.
Thank you very much, Midnight. And this is really a call for the right to have health and others, and the right to love. So we are going to talk next to Manoj, Mr. Manoj Padesi from the NCPI, who's based in India and works regionally. Manoj, are you here? If you can unmute yourself and put on your camera.
Yes.
Thank you, Manoj. So we heard from Midnight a very powerful appeal and a very powerful account of what has happened this year amidst all the disruptions. But for you and the communities that you represent, what should transformation of the AIDS response look like from the perspective of PLHIV communities, well, in the midst of these funding challenges? Over to you.
So thank you, Pauline and WHO for arranging this, especially on the World AIDS Day, and the theme is overcoming disruption and transforming AIDS response. So I will start with the PLHI perspective. So empower, engage, and promote entrepreneurship. This is the three things which I will share in the PLHI perspective. Like the previous speakers has already mentioned, in these 3 decades or more than 3 decades of work, every agency has invested in the community. So like all UN agencies, UNAIDS mainly penetrating the whole AIDS response urgency into the political space and giving space to the community. WHO play a role on very important treatment, shaping the treatment guidelines, educating community, increasing community ownership into treatment, and that whole things is now showing the result. Like that is why more than 70-80% people are adhering to treatment. Viral suppression, we are now aiming for 95, and all those stuffs are happening because of the previous investment. Now, the funding cuts is, even the midnight mentioned that lots of people lost their job and everything. What does it mean? That it affects first on the community at grassroots level. Whenever there is a funding cut, it affects at grassroots level. And if that happens, the program will get derailed. We already are witnessing and seeing that in some pockets the epidemic is still rising. Besides all the available tools of prevention and care and support and treatment, the deaths are increasing and new infections are rising. This is not a good scenario. And one of the reason is might be the shrinking space of the community. And Arun mentioned about domestic response should be strengthened, but domestic response will be very much needed. That is for facility or quality of service, strengthening that. The role of community is to take treatment or to take the prevention methods till the home door, like till the community at grassroots level. And the role which PLHIV community had played, especially in stigma reduction, which is the significant role which has helped in linking people to treatment, linking like for positive prevention and everything. Second role is mainly local ownership, engaging with local policy makers. That role PLHIV community and even key population has played very well. Treatment literacy within the community, that is actually very significant role which PLHIV community has played in the overall HIV response. And shrinking this all space is actually compromising all these achievements. It's actually compromising the stigma, is also compromising the literacy and everything. 2-3 things which we can ensure for the next step. The message, there are in the space now, Global Fund is one donor. US is coming back with some certain conditions, but treatment funding is still continue. And then domestic funding. Corporates funding are still, people are just talking, but it's like we can see, but we cannot access that. So that's the corporate funding for the CBO. Like everybody is coming and telling, oh, you access corporate funding, but it's very difficult to access that. So lastly, what I want to say is that the Global Fund might also get the minimum the last, and there might be 30% cuts. So these 30% cuts should not affect the community's work. The direct funding to the community, this should be at WHO level. If you people can engage at policy dialogue with WHO or with Global Fund and promote the direct funding to the community model. At domestic level, there are new innovations are coming, long actings are coming, which are proven for prevention tool. There are HIV self-testing models. These are differentiated survey delivery model. The governments can use the community. Use is a wrong word, but the government can work closely with the community to ensuring all these new tools will be actually helpful for the prevention and care support and treatment programs. It's a sad thing for, like, we all know what is the UNAIDS has been asked to shut down by 2026, but is like all UN agencies can think of supporting the community, facilitating the dialogue at the national level or between the corporate levels, because that will give the weightage, that will give us the credibility also, that the WHO or UN agencies are actually asking CSR to invest in the community. Those kind of things which you like that role can be played. And just increasing domestic response might increase the treatment or might increase the coverage, but ultimately the people, those who need that, we have to build that role community can play very, very well. And in this, I must thanks like the all UN, UNAIDS, WHO, those who invested in the community. I still remember the treatment literacy is actually deep rooted in our system. Is the credit goes to WHO. The shaping the national guidelines, removing the harmful treatments, bringing the new treatments, is all credit goes to WHO. These all things need to be retained. It should be maintained, and for that, let's think something um, which we can do jointly, which we can do together, and complement each others, and ensure that we transform this AIDS response and overcome this disruption. Thank you so much.
Very importantly, and thank you very much, Manoj, you brought out very, very key points on the really collaborating, but really importantly is beyond Global Fund and the other global health donors, is that it's a really need to leverage domestic financing, find what are the different mechanisms that would enable social contracting of communities, because the community leadership and delivery of services fulfill such an important and critical part of responses, not just in HIV, but in every part of trying to reach the most unreached and the most vulnerable. So please stay online, and for everyone to put your comments and your questions on the chat. And now we're going to move on to Ika. With pleasure, I would like to invite Ika Noviyanti from Youth Lead, that is actually working with a young key population organizations. And it's really critical because every country that I've seen in SEARO and most of Asia have seen increases in HIV and STIs in young people, and we are incredibly concerned. But being incredibly concerned is not enough. We need concrete actions and strategies that involve young people. So I would like to invite you that how can the AIDS response evolve to reflect youth realities, including mobility, digital engagement, mental health, and all the other barriers that are currently existing for young people. Over to you, Ika. Please unmute.
Thank you
you.
so much, Pauline, and good afternoon, everyone. As Pauline said, my name is Ika. I'm the regional coordinator of Youth Lead, the Yankee Population Network. We are based in Bangkok. So when we talk about the AIDS response, HIV response, and also Yankee population, and if we want to make the AIDS respond to truly reflect the youth realities, we have to redesign it around how young people actually live today, like mobile, digital, and also under economic pressure, and navigating the complex mental health landscape. I would say on the first thing around the mobility, young people are constantly on the move, either for school, work, migration, or safety. But the HIV surface still assume stability. We need portable treatment, multi-month dispensing, cross-border refills, interoperable digital records, and also outreach in the place young people actually pass through, like a campus, economic zone, entertainment areas, transit hub, because no young people should lose access to care simply because they move around. The secondly is a digital first approach. Young people on these days are already live online, yet much of our response still treat digital as an afterthought. So we need to CL online entry point for testing and also giving PrEP, or having like chat-based counseling, appointment reminder, peer support groups, and also youth design application that speaks our language. Because digital intervention should not replace in-person service, but it can remove barriers of distance, also stigma and privacy. The third one, on the mental health area, depression, anxiety, and trauma are major drivers of disengagement among young key population, and also young people living with HIV. So integrating mental health screening and peer support into every HIV service point, physical or digital, is no longer optional, but it's a must. Investing in youth peer counselors is also one of the most effective ways to improve adherence and also well-being. On the socioeconomic barriers, many adolescent and young key population face unstable housing. Often also young people get lower income, and also for the LGBTIQ plus community, they're facing like school disruption and also criminalization in the place. So for them, HIV service must be paired with the social protection, transport, food support, education, subsidized legal aids, and also flexible clinic hours that fit real lives. And finally, we talk about power. Youth-led network must be resourced and also respected as an equal partner. So when young people shape programs, design digital tools, and also lead the community monitoring, service become more relevant, more trust, and also more effective for the young people. Ultimately, evolving the AIDS response means moving from a system that asks young people to adapt to a system that adapts to young people, where mobility is a normal. Digital space are part of the care, mental health is central, and socioeconomic realities are addressed, and youth leadership drives the agenda. I think that's all that I want to say. Move to you, Pauline.
Thank you, Ika. And that's a very clear description of what is required and needed to make sure that we are not losing our young people. And having said that, the data currently is being seen in Asia Pacific is already several countries have more than 60% of their new HIV cases among people that are young, less than 25 years of age. So it is really concerning that even with we have increases in antiretroviral coverage, our HIV epidemics in the most of Asia is generally considered low prevalence or concentrated epidemics. We see these red flags that show that not everything is well. So it is really something that we have to move forward and to really transform the responses in every country to make sure that communities and in particular young people are also included in the conversation and also the reprogramming. Thank you. So here I would like to call upon Dr. Rosapon from Thailand in addressing other related syndemics, and what are some of these gaps in STI response, and how can healthcare providers work more closely with communities and affected people to ensure integrated stigma-free HIV and STI services. Over to you, Dr. Rosapon.
Thank you very much. Thank you for inviting me to join these sessions. So, may I share some slides, please? Okay. Okay. When we talk about STIs, we usually think of patients who come to the hospital because they have symptoms. And these are the cases that we see every day, but actually only the tip of the iceberg. These are the cases that we have seen, but beneath on the surface of the icebergs are many individuals with asymptomatic STI. People who do not feel sick, and therefore they never seek care. These hidden infections continue to drive transmission, including HIV. If we aim for zero new HIV infections, we must go beyond treating symptomatic cases. We must actively identify asymptomatic infections and bring people into care earlier. But to do this effectively, we also need to recognize the system barriers that stand in our way. STI services in many settings remain fragmented, with outpatient departments working in parallel rather than in an integrated manner. Stigma and discrimination within healthcare systems continue to discourage timely testing, particularly among key populations, including youth. In addition, limited rapid diagnostic tests, weak partner notification, and also inconsistent linkage to care. Those undermine our ability to provide comprehensive and timely STI management. Before discuss about the community approaches, I want to highlight the importance of strengthening our hospital environment. One example in a hospital in Thailand is a routine screening program implemented in the outpatient department. At the first screening point, every patient is asked with few simple, non-judgmental questions to identify those who may benefit for HIV and syphilis testing. This approach allows us to detect infections that would otherwise be missed and ensure that screening does not depend solely on individuals volunteering sensitive information. Beyond hospital-based efforts, partnering with the community is essential. As you already heard from the people from the community already discussed on this. So co-creating services with community-based organizations ensure that programs are appropriate, accessible, and aligned with the real needs. Engaging communities as equal partners is a critical first step. Inviting key population and also people living with HIV network to participate in the planning, service design, and also evaluation to ensure that services reflect live realities. Joint needs assessment, community consultations, and patient journey mapping to help identify barriers and inform to redesign of care that is acceptable and accessible. For hospital side, of course, that they need some improving on provider attitudes. Is also the thing that is essential. On regular training, on stigma reduction, non-discriminatory communication, and supportive environment, including community voices in this session, further strengthens understanding and empathy. At the same time, offering integrated one-stop services, combining HIV testing and STI screening, reproductive health services, and prevention options such as PrEP, condom use, vaccinations to help reduce fragmentation and increase service uptake. So partnership with a community-based organization enhance outreach, peer navigation, and follow-up support, which are especially important for individuals who face barriers to accessing facility-based care. Ensure confidentiality through clear privacy protocol and private service space, encourage people to seek testing and treatment without fear of judgment. Over now. Sending to you, Pauline. Thank you very much.
Thank you, Dr. Rosapon. And one might actually try to understand why is Dr. Rosapon here? Because actually she's coming from the perspective of STIs. But what Dr. Rosapon also underscores is that it is not just HIV, it's the complete package of services and person-centered services throughout the life course that is important. Whether it's prevention, preventing through PrEP, people from getting HIV is STI treatment if they are not HIV, But very critically enough is that all the other person-centered care that is required, vaccinations, for example, for people who are most at risk. So these are all in the package of services that are required for a person who is more at risk, or even when they're not at risk. So thank you, Dr. Rosapon, for bringing this perspective in. And we're going to move to the last speaker, Dr. Cheryl Johnson, a colleague from WHO headquarters. And from WHO's perspective, which priority interventions will be most critical for countries to accelerate progress towards the 2030 HIV and STI targets despite all the ongoing disruptions? Over to you, Cheryl.
Excellent. Thank you so much. And what a privilege to be a part of this webinar with so many excellent speakers raising such critical points about the priorities in SEARO and globally. So I wanted to start, we already kind of know the interventions that are the most important, but I think what's most difficult now is thinking through how we will actually do more with less. So as many of the speakers have already outlined, with reduced funding, with kind of the changing landscape, it's not so much whether, what should we do? It's really how should we implement these interventions moving forward. I think one of the strategies I wanted to talk about to start was something more cross-cutting. When we really look at the evidence across HIV and beyond, there's increasing focus on self-care and what self-care might entail. That includes not just maybe HIV self-testing or more broader self-testing approaches. It also includes the delivery of prevention and treatment to really go into more self-management. And why there's, I think, such a big focus around this is, one, we know self-care can increase accessibility and acceptability. It's something that can enable us to be more targeted. And it's also something that we've seen data across service delivery that really helps with effective use of interventions. So it gives people more flexibility, autonomy, engagement, empowerment, and it really does put people first as a way to optimize their own care. So it's not going to be an approach for every single person, for every single situation, but it does, I think, add something to the broader ecosystem of service delivery. And ultimately, I think, especially right now, there's been increased focus on self-care because of the cost savings potential and needing to address like gaps related to health workers, shortages in terms of staffing, as well as cost containment priorities. And maybe one of the things we've really learned in the HIV response that I think is, relevant for STIs and more broadly is, one, it's not a zero-sum game with self-care. So there could be a broader continuum of how we think about things that might be pure self-care, whether that's a sexual health choice, versus maybe things that are more self-directed or shared, which could be things like self-testing or monitoring, as well as things like multi-month dispensing, engagement and prevention, and even strategies through AI and digital tools that can support in this kind of gray space. And then there will always be, I think, a role for more clinical management and at a health worker-led setting that isn't going to be self-care. So I think this is more of like the universe of how different strategies might fit and how even small adjustments in a program might improve the access and experience that a client has with their own services, but also really enable more savings or benefits to the health workers. And so there's just, I think, a range of strategies. So if we kind of think about then the pyramid, there's different entry points for self-care too. There may be things that are very much led by the individual outside of the health sector, but then there's also things within the health system where self-care could still play a role. For instance, we have facility-based self-testing, or we might have observed therapies, and we have some different strategies and options. So I just wanted to maybe flag those items as something to think about more broadly. When we think about what interventions work, we know self-care works, It's something that can be expanded across testing, prevention, and treatment. And a sister kind of systems approach is also virtual. So we know virtual interventions are really critical to delivery across testing, prevention, and treatment for HIV, STIs, and hepatitis. And maybe the first thing in this slide was prepared by Purvi Shah from WHO and UNAIDS at the time, really highlighting that there are billions of internet users. There's lots of opportunity to really engage people through social media, as well as through follow-up care. So I think this is a critical opportunity where there's a lot more information available now about how we can access virtual interventions and utilize these across settings to increase our reach. And I wanted to highlight that actually for key populations, we do have a recommendation that online delivery of HIV, viral hepatitis, and STI services may be offered. And we do see these as important. They won't always replace all the in-person face-to-face services, but they do complement and provide an important strategy for many people. And as many people know on this call, there's the rise of artificial intelligence that I think across domains is really transforming the different ways we can implement services. So there will always be a human in the loop for supervision and responsibility for the use of these tools. But I think their role in replacing some of the counseling time, streamlining consultations, helping with symptoms and identification and diagnosis, providing telehealth. Really, this is something across testing, prevention, and treatment for HIV, hepatitis, STI that we are seeing more and more as a great opportunity for us to be more efficient and effective in our services. Now, as we've talked about, I think self-care and just broader virtual tools, I wanted to also then think about other strategies that we're seeing come to the surface around simplification and low-cost diagnostics as being one of them. So this came from that same sustaining the HIV, hepatitis, and STI response, where we see that in testing, often many programs are still procuring products that are much higher cost than what's listed in the WHO catalog. So I do think it's important to emphasize that you can achieve similar or even greater impact by maintaining testing volume, by opting for quality assured, pre-qualified tests that are cheaper. And we've seen that some countries could be able to have as much of a 30% reduction in costs to their testing program just by switching to the lower cost products on the list based on what their average weighted price is. And I think more flexibility of embracing self-care and even multi-disease approaches, which I'll touch on in a little bit, are very important as ways to be a little bit lighter touch and easier for clients to access and for health workers who are overstretched to deliver programs. And connected with this is our simplified quality management systems toolkit. So many programs have been spending a significant amount of resources on quality management, which is so critical to our work, but it can be simplified. So the new WHO toolkit that's just come online in the last couple of months really does phase out the 12 quality system essentials to just 6 pillars, to something that might be easier to finance and support with more limited resources across settings. And this is a toolkit focused on non-lab settings, which is where we know the bulk of our HIV testing and a lot of our general testing is performed. And so it does provide, I think, a really useful multi-disease approach for how we might approach quality management systems in this new time. And then I wanted to spotlight integrated testing tools and integrated services. So this is something I'm showing just in some diagrams. We've had some really fantastic success, and you can see through the green kind of map here that particularly in Southeast Asia, we have seen some gains with the growing use of the dual HIV syphilis rapid test. And we're up to 95 countries actually using this product. And I'm really delighted to share that because when I started my time here at WHO, we had very small numbers of people engaged in using this product. And it's something that's increased over time. And often when we look at product introduction, we're not able to see what the impact is at different levels. I might be able to show you a map, but I couldn't tell you what the trends in testing might be. And I'm really pleased to show the second graph here that over time we're seeing by programs introducing an HIV and syphilis dual test, the gap between HIV and syphilis testing is shrinking. If you compare where we are in 2024 compared to where we were in 2021, the dual test is making a difference. And I think that it's this trajectory and the lessons learned from this tool that are giving pause and reflection that, maybe other multiplex products could achieve similar gains. And we know in Asia, there's actually a lot of different commodities and different products in this space that, if quality assured, could have similar results, not just for HIV, but for STIs more broadly. And so this is an area that we've been really championing, looking at the evidence for, and are really grateful for Pauline and her leadership of prioritizing multiplex early on at the WHO. And so this is something I'll share a little bit about our guideline development. But I think this experience of what works is we do see these integrated diagnostics achieving results. And there is, I think, an opportunity to do more, particularly with reduced health worker time. Just having one test instead of having multiple tests would be game-changing in a lot of settings. So I wanted to spotlight also not just the dual test, but what we're seeing in the molecular space. So, thanks to all the investment that came through the COVID-19 pandemic to the diagnostic space, we're reaping the rewards of many of the innovations in diagnostics that are now coming to scale to really say multiplex products are not just serology or just in a centralized device in a lab. We are seeing point of care tools for gonorrhea, chlamydia, and hepatitis and other STIs. And while the scoping review we conducted and presented earlier this year at the IUSTI conference showed that they were accurate, scalable, acceptable, and affordable across populations, there was limited evidence around effectiveness, which is what we focused on in our guideline process. So while I can't tell you what the outcomes of our final guidelines are, those are in development and those will be released next year, we're really optimistic about the future of multiplex testing and its role in the response moving forward. And maybe some important updates I'd share is, one, we pre-qualified the first triplex product at WHO in July of this year. So this is the first panel of the HIV, hepatitis B, and syphilis panel for targeted for antenatal care. So that's something that's available for procurement. We announced the guideline development process. So I would just say expect this to come out soon, and we're very much looking forward to that. And we're seeing important investment in this space. So for Safe Start Plus, this is a program funded by Unitaid that's really focused on scaling up these integrated services and features multiplex testing quite prominently. And then maybe just a additional point is the Unitaid call for proposals for integrated diagnostics. So this is available and actually open for submissions up until the 19th of January of next year. And lastly, I know there's been a lot of discussion around HIV prevention, huge gains and innovations around prevention, particularly around lenacapavir with the guidelines launched this year. And while I'm running out of time, I think the point I would raise here is that the guidance available really highlights that Len is really supposed to be an additional prevention choice alongside a package, a combination approach to prevention. And there's a lot of strategies that can be leveraged that are already in place in the prevention space. So it's not just bringing a new thing, it's really incorporating it into something that's really focused on meeting a broader prevention need with different choices and options for those who may benefit most. While this highlights some of the implementation considerations and research gaps, I think there's a lot we'll have to learn through the scale up and implementation in countries. And I think we're all eager to see what country adoption is going to look like in 2026 and beyond. There is a provider training toolkit that's available. And so this QR code may be very helpful for you to think about accessing so you can get all the latest information about how to implement lenacapavir and broader PrEP and prevention programming. Now, one thing that always comes up in the LEN discussion and the long-acting discussion is the testing. And I just wanted to reiterate that, with the new innovations, sometimes the testing, keeping it simple, is the best strategy to enable access. So this is just a summary of our systematic review and evidence where we continue to reiterate that rapid tests and even self-tests in some settings may be the best option to ensure everybody can maximize their prevention benefit through some of these new exciting tools. And we are seeing lots of engagement around self-care again, just to come back to that in the PrEP space, that I think this will continue to be a really important strategy to address gaps in HIV prevention, particularly in Asia. Many countries are going to continue to do research. And so I just thought I'd single out to say we did a mapping of what countries we're looking at in terms of their testing and their implementation of lenacapavir. And we do see more decentralized testing, more self-care, and more multiplex testing coming into this in the future. So with that, I just want to say thank you so much. Apologies for running over a little bit, just very enthusiastic about all the innovations. And thank you again to the organizers for this excellent webinar. Back to you, Pauline.
Thank you very much, Cheryl. And so we are actually to time, but I would ask for a couple more minutes. I'll pass the baton over to Pruvi because we have a poll. We would like to know what you think. So Pruvi, over to you.
Thank you so much, Polan, and thank you everyone for the great presentations and such passionate appeals that we've seen today. I think it's extremely important that we all work together and keep the community at the center while doing all the planning and implementation strategies that we're looking forward to. I'll just do a quick poll just to get some responses from the audience as well. So if we can have the poll. Please click on the link that you can see in the chat and you can register your responses to this question. So the question is, what comes to your mind when you think of the theme this year, which is overcoming disruptions, transforming the AIDS response? You can write one-word responses. You can put in your multiple responses as well, but we would like to know what exactly comes to your mind when you first read the theme of this year. And the link is in the chat. Please click on the link and you will be able to enter your responses. So we are looking forward to that. We just have a couple of minutes for this. So request everyone to kindly click on the link and respond to this poll, please. So we have our first response, which is anger. I think a lot of people that I have interacted with have had the same emotions. And there are positives to it as well. Some people see it as an opportunity to focus more on community needs and preferences, build community resilience, yes, and also look at innovations on how we can, reduce the burden of the healthcare providers as well as continue providing services. It definitely needs more expansion, and resilience is key. Absolutely. Absolutely. Integration is going to be a key word moving forward. We will need to look at opportunities where we can integrate different components to ensure a holistic care approach or a self-care approach, as Cheryl was mentioning very rightly, for our populations to ensure that everybody gets access to service. And lots of new hope as well. Sustainability is going to be key while planning itself. So please continue to providing your responses to this poll. We'll be very happy to collate it and report it. I will move to Dr. Polan for closing remarks, please.
Thank you very much, Pruvi. I have to say that we have lived through this year all together, and it's been difficult, challenging. It's all what you have put there on the poll. It's in some parts of the year we were just as I say, there's nothing to say because we are living the difficulty. So going forward, it is important that we work together. There's been a lot of really deep reflections from our speakers, both from the community, from the programs, from national programs, from WHO and UNAIDS and all the other UN agencies that also lived through the difficulty of these funding cuts. But really importantly is that even with the challenges, we have all changed we have evolved. We sometimes with less resources, but we have all evolved and we have to move forward together. So I would say thank you very much for your time today. It's been an incredible conversation that we have had, and I wish you next year that we look towards hope and to work to continue to work together so that we can overcome all the challenges that we will face. I would like to thank the panelists and to give them a round of applause. Our ECHO team that has underwritten all our logistics for the series of webinars, including this. Our WHO senior management that is superbly supportive of all the activities that we have worked on with all stakeholders, my colleagues at the WHO country offices, and our UN colleagues that have been trying to work and serve communities despite all the challenges. And I'd like to especially thank Pruvi and my colleagues Balraj, Tanu, and Karina that has been a part of the WHO team. Thank you very much all, and thank you for listening in for this year's World AIDS Day webinar. Have a good day.